Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome students. Today we are starting our surgery lecture number 12, Cholelithiasis, that is the gallstones. In this lecture, we will see Cholelithiasis, gallstones, types of the gallstones, acute cholecystitis and pancreatic reflux. First, gallstone means the Cholelithiasis. The incidence of the gallstones forming are common, rare in first and second decades. Incidences gradually increases after 21 years. Women are more affected than men. Ratio is 4:1. There is a 4F for gallstones forming in the female, that is the fat, fertile, female and 40. Fat, fertile means multiparous, female of 40. Major elements: cholesterol, bile pigments and calcium iron carbonates, phosphorus, proteins, mucus, cellular debris and the carbohydrates are the major elements of the gallstones. Pathogenesis of the stones, that is the metabolic factor, reflux factor, stasis factor, infective factors. Here is the image. You can see the gallbladder contains the faceted multiple gallbladder stones in the gallbladder. Here is a good picture. Next image is the typical faceted gallbladder stones. This is the another image of the gallbladder stones. Now the metabolic factors are: solubility of the cholesterol depends on the condition of conjugated bile salts and phospholipids. Lecithin is the predominant phospholipid in the bile. Cholesterol is insoluble in aqueous solution but dissolved by the bile acid. Normal ratio of bile acid to cholesterol is 25:1, but ratio falls up to 13:1. The cholesterol precipitates and thus gallstones forms. Second factor is reflux factor. Pancreatic enzymes have been detected in gallbladder. Third is the stasis factor, temporary cessation of bile flow into the intestine and stagnation of bile in the gallbladder. Fourth factor is infective factor, major cause of formation of gallbladder stones. There is a very good Moynihan's aphorism that a gallstone is a tombstone erected in the memory of organism within it. Means the every faceted stone of the gallbladder is the stone which is the erected stone in the memory of the organism, means bacteria in it, is still true today. E. coli, Bacterium, typhosum and Sterptococcus is the bacteria which is causes for the gallbladder stones. Through bloodstream, bowel through the lymphatics, these organisms goes into the bile and they die there, and the stone formation around there. That is why the tombstone is erected in the memory of the organism is saying by the Moynians. Now the types of the gallbladder stones are pure stones and mixed and combined gallstones. Pure stones constitute approximately 10% and mixed and combined gallstones contributes 90%. Pure stones, A type is cholesterol stones. Commonest type, solitary and smooth surface, oral, round shape, light in color, pale yellow, bile pigment are deposited within it. B. Pure stones type is pigment stones, may be pure or consist of calcium bilirubinate, black or dark brown in color due to excessive breakdown of hemoglobin, also found in intra or extrahepatic ducts, contains bilirubin and cholesterol, caused by infection, parasites and E. coli. Mucin and glycoprotein is also present in calculi of bilirubinate stones. A third type of the pure stones of gallbladder is calcium carbonate stones, rarest type of stone. This is greyish white in color with smooth surface. Here is the image of types of gallstones. First image showing the cholesterol stones, second is the pigment stone and third is the mixed stones of the gallbladder. Here is also the another image. Now the second type of the gallbladder stone is mixed and combined stones, which contributes 90%, varying proportions of the all three of the stone forming constituents of the bile, that is the cholesterol, bile pigments and the calcium. Surface are faceted by mutual pressure, vary in size up to 2 cm in diameter. Color determines the predominance of stone forming constituents. Cholesterol is yellow colored, bilirubinate is black colored, calcium carbo is greyish white colored. Central nucleus contains epithelial debris and bacteria. Mixed stones are frequently associated with cholecystitis. Effects and complications of gallstones are in the gallbladder: asymptomatic gallstones, hydrops of the gallbladder, flatulent dyspepsia, Gallstone colic, acute obstructive cholecystitis which may lead to mucocele, empyema, gangrene, perforation of the and fistula formation, chronic cholecystitis and carcinoma. And effects and complication of gallbladder in the common bile duct is obstructive jaundice, liver failure, cholangitis, acute and recurrent pancreatitis. Effects and complications of the gallbladder in the pancreas are acute pancreatitis, acute relapsing pancreatitis, chronic pancreatitis, and effects and complications of the gallbladder in the intestine are gallstones, ileus. Gallstones may be associated with other diseases in the body. Now, saints triad are gallstones, hiatus hernia and diverticulosis of the colon are the saints triad, called as the saints triad. All these three conditions are present in the saints triad: gallstones, hiatus hernia and diverticulosis of the colon. Obesity may be the single common factor in saints triad. Cholecystic heart. Disease of gallbladder may cause decreased coronary blood flow, arrhythmias or heart block, known as a cholecystic heart. Asymptomatic gallstones. Liberal use of cholecystography and USG has resulted in the diagnosis of the asymptomatic gallstones. 50% has turned symptomatic and serious complication in 20% only. Most dreaded complication is the carcinoma of the gallbladder, which is contributes only 1 to 15%. Hydrops of the gallbladder is cholesterol type of gallstones may impact in the cystic duct or neck of the gallbladder, resulting in hydrops. Bile is absorbed and the gallbladder becomes filled and distended with mucus. It is called mucocele of the gallbladder. Now, the flatulent dyspepsia. Gallbladder stones may cause for such symptoms of filling or fullness of the food, blanching and heartburn. Gallstone colic. Small calculus accumulate at the neck or in the cystic duct. Muscles of the gallbladder contrast vigorously to expel those calculi from obstructing its mouth. That is the biliary colic. There are 4 types of colic pain. Among of that, this is the biliary type of the colic. Usually occurs at night. Pain referred from the right scapula or right shoulder. Jaundice may follow on attack of the gallbladder colic. Now, the acute cholecystitis. 90% of cases of inflammation of gallbladder is associated with calculi. Pathogenesis behind the acute cholecystitis, there is the 4 factors: obstruction or stasis, chemical irritation, bacterial infection, pancreatic reflux. First is the obstruction or stasis. Stone obstructing the cystic duct. 80% of cases, kinking of gallbladder or duct or pressure adjacent structure may cause non-calculous obstruction. Edema or erosion caused by the stone may cause destruction of outlet of gallbladder. Obstruction will cause stasis of the bile, leading to progressive concentration of bile and chemical irritation of the gallbladder wall. This is the image of the gallbladder acute cholecystitis, which showing the pressure of the gallbladder wall. Gallbladder is distended, edematous gallbladder, cystic duct is narrowing, the gallstone impacted in Hartmann's pouch, increased interluminal pressure of the gallbladder. Gallbladder is distended, fluid secretions and prostaglandin I2 and E2 secretions. Here is another image of acute cholecystitis. You can see on your screen there is a stone in the gallbladder. Second factor is the pathogenesis. Pathological factor is the chemical irritation. With concentration of bile or erosion of the mucosa by a stone, erosion gives access to the bile salts into the planes. Bile salts are very toxic to cells, and this causes destruction of the cells and chemical cholecystitis. Causes congestion of the gallbladder will make the gallbladder a prey to chemical irritation by the concentrating bile. Third pathological factors are bacterial infection. Approximately 5 to 10% of all cases bacterial infections contributes. Common offending organisms are E. coli and Sterptococcus. Aerobacteria aerogens, Klebsiella, Salmonella, Clostridia and Staphylococci. Gallbladder may be secondarily involved by the bacterial invasions. Fourth and final pathological factor is pancreatic reflux. Active lipases, amylases and proteases have been identified in the bile in the patient suffering from the acute cholecystitis. Pressure in the pancreatic duct is generally greater than that of the biliary tract. Presence of a common channel permits entry of pancreatic juice into the gallbladder. Now, the pathology: gallbladder is enlarged usually 2 to 3 times, becomes bright red or violet to green, black in color. Serosa becomes congested, covered with fibrinous exudates and have areas of the gangrene or necrosis. Wall of the gallbladder becomes edematous and thickened. When the content exudates is virtually pure pus, the condition is called empyema of the gallbladder. Cystic duct obstruction is essential for development of empyema. Mucosa is hyperemic and may show necrotic surfaces in severe cases. This condition is called gangrenous cholecystitis. Here is the image. We can see the pancreatic reflux, gallbladder, and the bile juices is retroverting into the stomach via duodenal second and first part. Second image showing the pancreatic reflux. Perforation through the site may rise to biliary peritonitis, localized pericholecystic abscess, cholecystoenteric fistula, internal fistula. Clinical features, symptoms, agonizing pain in right upper quadrant of the abdomen and may be referred back to the inferior angle of the right scapula. Nausea and vomiting are important symptoms are seen in 70% of the cases. Sign: pyrexia, jaundice, tenderness, rebound tenderness. Pyrexia is a regular features of acute cholecystitis. Jaundice is present in 10% of cases due to entry of bile pigments into the circulation through the damaged gallbladder mucosa. Tenderness in right upper quadrant is a reliable finding. Rebound tenderness may also be present when the parietal peritoneum is inflamed. Now the Murphy's sign. What is the Murphy's sign? During deep palpation of right upper quadrant, the patient is asked to take deep breath in and out. Patient complains of acute pain during deep inspiration with inspiratory arrest when the tender inflamed gallbladder comes down and touches the palpating fingers. This is the Murphy's sign. Special investigations: blood. Leukocytosis presents in 85% of cases. Increase of serum bilirubin and serum amylase. Straight X-ray. Only 15% of gallbladder are radio opaque. Cholecystography, that is the IV cholangiography, should be performed. Cholecystography performed with a derivative of technetium 99M. Immunodiacetic acid technetium IDS scan. This is the only specific test for acute cholecystitis. Obstruction of the CBD or the hepatic duct is also detectable by this scan, but they are more clearly visualized by PTC or ERCP. Next investigation is ultrasonography. Differential diagnosis of perforated and penetrating ulcer, acute pancreatitis, acute high retrocecal appendicitis, acute pyelonephritis, gallbladder colic and hepatitis. We can differentiate this diagnosis with all these diseases. Complications: perforation of biliary peritonitis is there, pericholecystic abscess, internal fistula perforated into GI tract. Treatment: conservative treatment followed by elective cholecystectomy. Conservative treatment: the aim of the conservative treatment at setting a situation of functional test for the gallbladder and relaxing the spasm of the sphincter of Oddi. This can be achieved by NBM, nil by mouth. Nothing should be taken by the enteral route, and Ryle's tube aspiration. IV fluids should be given. Anticholinergic drugs to reduce the gastric and pancreatic secretions. Analgesics to combat the pain. Morphine and petridine should be avoided, which causes the spasm of the sphincter of Oddi and which causes the biliary colic. Fourth line of treatment is antibiotic, should be started immediately to control the inflammatory process. Oral cholecystogram is advised 3 weeks later. Cholecystectomy is advised 8 to 10 weeks after the acute symptoms have subsided. Surgical treatment is cholecystectomy. Duct, there is a 2 method. Duct first method, which is the popular, and second is the fundus first method. Duct first method is popular because of only if you dissected the cystic duct first, then it is the very safe side to trouble to the CBD. Charcot triad. History of jaundice, acute pain and fever. These 3 symptoms called as a Charcot triad: jaundice, acute pain at right upper quadrant and fever. Laparoscopically, cholecystectomy is also treatment of choice of the surgeons of today. And ESWL, that is the extracorporeal shock wave lithotripsy, is also useful but not routinely used. This technique in the gallbladder stones to dissolve it. Oral dissolution therapy. 80% of gallstones are predominantly composed of cholesterol. Stones are unable to dissolution therapy. Chenodeoxycholic and ursodeoxycholic acid are naturally occurring bile acid may be given orally for gallstones dissolution. Bile acid synthesis from cholesterol in the liver may be increased by ursodeoxycholic acid. Gallbladder should be functioning and stone should be radiolucent and less than 15 mm in size. Non-functioning gallbladder, radio-opaque stones or pigment stones are contraindicated for this therapy of oral dissolution therapy. Stones of 5 to 10 mm in diameter usually dissolve within 1 to 2 years. Remember, duration of treatment is about 18 to 24 months. Direct contact gallstone dissolution therapy is A 5 French pigtail polyethylene catheter is introduced transcutaneously and under the fluoroscopic and ultrasonographic control. 5 to 10 ml of NTB, that is the methyl terbutyl ether, is repeatedly instilled and aspirated through catheter. MTBE means methyl terbutyl ether rapidly dissolve the colorectal gallbladder stones in a few hours. Drawback of this technique of direct contact gallstone dissolving therapy are difficult in inserting the catheter stones with calcium. If the stone is with calcium, then it will not possible to dissolve by MTB technique. Toxicity of MTB highly inflammable. This solution is highly inflammable and causes for the anxiety, nausea and vomiting. Now, post cholecystectomy symptoms. Majority of the patients are relieved of symptoms after cholecystectomy. Unfortunately, in 15% of cases, the same symptoms persist following cholecystectomy. For this term used post cholecystectomy syndrome. Cause may be extrabiliary disorders, disorders of the extrahepatic biliary tract. First cause is extrabiliary disorders, condition like hiatus hernia, peptic ulcer and chronic pancreatitis. B type is the causes for post cholecystectomy syndrome are disorders of the biliary tract, residual stone in CBD, stricture of the bile duct, cystic duct syndrome, biliary dyskinesia, fibrosis and stenosis of the sphincter of Oddi. Guys, to clear your concept, there are some good videos and with animations are available on the YouTube. You can refer it, watch it, and here is the end of our surgery lecture number 12, that is the Cholelithiasis, gallbladder stones. Thank you.